Good morning, everybody. So I'm Manisha, Kumar, I'm a GP, and I've been a GP in Moss Side and Rusholme for over 20 years, and I am the Chief Medical Officer for NHS Greater Manchester Integrated Care, so our integrated care system. Now, I know a lot of you are STs in the room, always happy to send you slides about what is an integrated care system, but essentially, we've got the budget and we have to make the difference, and that is commissioning and making sure we have high quality healthcare for everybody, everywhere across Greater Manchester. Now, Laura didn't tell me how this one works. Let's see if it's intuitive. Okay, so health inequalities. What I don't want to do today is tell you things you know, but I think it's often worth us going over what we think we understand about health inequalities, but also how us as systems can create and embed and entrench health inequalities without even really understanding what we're doing just by the things we don't do. And I have seen this day in, day out in my surgery, which is why I think a lot of the GPs who are here have stayed where they work because they can see the difference that it makes. So health inequalities are defined as avoidable differences in health outcomes between groups and populations, how long we live, the age at which we get preventable disease or health conditions. It's a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. And what I want you to think about through the course of the day, saying what are you responsible for? What are you accountable for? What is your job to communicate? But absolutely, what is your job in the room to influence? Because some of these things aren't directly in our control, but if we don't do anything, we will just compound them. You know these are all the protected characteristics we've got. We've got age, disability, gender, marriage, wider determinants, education, geography, population, and of course our vulnerable groups. I'm not going to touch on Core 20+5 today, but it's really important that you understand that because that's the national framework to try and look at how we're going to look at those populations that have multiple disadvantage. And I think we're only at the beginning of what the Core 20+5 healthcare strategy could mean. But what does levelling up mean? What does it actually mean for your health outcomes? How many of you seen the tram map of Greater Manchester and the ages? So we know that, back in Didsbury, you're doing much, much better than if you live in Moss Side and Rusholme. And that feels unfair. And if something feels unfair, I think we have a responsibility to create fairness. So smoking-related cancer, 3 times higher for the most deprived populations. People will say, well, they smoke more. Well, why do people smoke? Why don't people understand? Everybody who smokes knows that they shouldn't be smoking. But sometimes their lives are so complex that this isn't their priority. And therefore, the lifestyle choices people make are absolutely related to the lives that they lead. And to change some of the choices they make, we have to give them opportunity and hope, which is harder to do in your surgery. People living in the most income-deprived areas in England are 20% more likely to have a late cancer diagnosis. They're less likely to attend screening. Teenage girls living in deprived areas are less likely to receive their HPV vaccine. Now, these are avoidable differences across our country. Cancer survival rates more improved for people living in affluent areas. If you are richer and whiter, you're more likely to be on a research trial than you are if you aren't. If you are, and John will evidence this, the more deprived you are, the less likely you are actually even to get onto an elective care waiting list, never mind reach the top of it. Now, those things don't feel fair. Socioeconomic status can impact on your access to information, social care, and practical or emotional support. Now, if we're really going to level up, how can we look at that across the system? So, Greater Manchester, population of 2.8 million, economy bigger than that of Wales or Northern Ireland. Population is growing really quickly, particularly across the city centre and across Salford. However, the wealth we're seeing in the city is concentrated in certain areas. It isn't really yet spilling over into the populations that we are working with on the fringes of that city centre. Greater Manchester has some of the lowest life expectancy in England, with differences between the most deprived areas of quite a significant amount and further differences related to your protected characteristics. And it shows how some of those issues of compounded deprivation are affecting health. So a quarter of Greater Manchester adults are economically inactive, above England as a whole. And for people with minority ethnic groups in Greater Manchester, employment rates are over 10% below the overall working employment rate, and that's worse with people with a disability. If you are both ethnic minority and disabled, you can see how your life start and your life opportunities are going to be harder. There's a big conversation as whether we're the most deprived integrated care system or whether there's a couple that are bordering us, but we're definitely in the bottom 3. And if you look at how healthcare is funded, there are allowances made for deprivation, but not as much as the allowances made for older age or long-term conditions. So the money we get probably doesn't answer the need that we have. And those of you who've worked in surgery with people whose ask and need is wider than health, you will know that the time you get never is enough to deal with those deeper issues. But we can do that differently across Greater Manchester. Very little bit about the integrated care system, divided into 3 parts: the whole of Greater Manchester and the hospitals that we've got. We've got 14 NHS trusts, local places, the 10 places in Manchester, and those really align with the 10 CCGs for devolution. But the most important bit is neighbourhoods, and the 66 neighbourhoods currently designed on a primary care network footprint, but actually we need to look wider into integrated neighbourhood teams, because the difference we can make doing scale solutions, but absolutely I'm going to come back to a little bit about personalised care in place that's important. So what is our shared vision? And this is something that I think we need to hold on to. We have a 5-year strategy to make a real difference. Everyone has an opportunity to live a good life. Everyone has improved health and well-being. Everyone experiences high-quality care and support where and when they need it. And our health and care services are integrated and sustainable. Those of you who've worked in Greater Manchester or Manchester for a while will have known devolution. Now, did devolution make a difference? What is the difference of an integrated care system? Why are we doing this differently? Why can't health just be health? And I think you're in this room because you know that it doesn't work if health is just health. We need to look wider than that, because what influences people's health is outside our direct control. So back to that RACI, responsible, accountable, communicate and influence. So devolution for us in Greater Manchester, we did see an improvement in healthy life expectancy. We didn't really break that down in terms of protected characteristics because we weren't really measuring that. And I think something I want you to think about throughout the course of the day is, what do we want to measure that really shows we are succeeding? But we did learn a lot from Devo that I think we need to take into the next 5 to 10 years. And the challenges facing the health and care system can limit improvements in health. Improved health is not the role of the NHS on its own. It takes time to make a difference. If we're going to look at a looked after child and trauma-informed care, we will see the change in their health outcomes in 20 or 30 years. Health services work on a 12-month, if you're lucky, 9-month financial cycle. So how do we really get the evidence to the forefront of people's minds? Partnership is important, and that importance of neighbourhoods. Relationships and leadership are crucial. So what you take away from today into your leadership within your roles is important. We need to hold each other to account. Governance, that's a whole other topic. I can happily come back to talk to you about clinical governance at another time. The challenges to integration are common to all systems, and reaching and supporting those facing the most entrenched inequalities and disadvantage requires radically different approaches, and that challenges universal service delivery. Now, I don't have the answers to what we do, but perhaps you all do, and that's what I want to hear about. So I'll be touching base with Laura after, particularly at the end. What are those changes you want to see? So a little bit of a challenge to you. You'll have all heard of proportionate universalism. Anyone prepared to give a stab at defining it right at the beginning of a day in a room of people you don't know? No, don't worry. So these slides can go out because actually it means that you send the resources to where you have the most need. Now, as a system, we have minus £650 million this year. So we're struggling a little because we have minus money. But are we really prepared to make that difference? Are we really prepared to say, OK, I'm all right in Didsbury, not great, not as great as Frimley, but Oldham need that money more. So we're going to shift the investment to bring Oldham up to the best of Greater Manchester, and then Greater Manchester up to the health outcomes of the country. I'm not sure we're prepared yet to do things differently, but we need to look at what that looks like. Conscious and unconscious bias. The fact that you're all in the room, I would say most of you feel that you are really open to looking at health inequalities and deprivation and seeing people as their whole. But actually, in the healthcare system and in our local authorities and in our political world, we do have conscious and unconscious bias. And sometimes just being aware of your bias is really important as how you might change your system. Access in your GP surgery, do you do the ones without an interpreter first? Because they're quicker and it makes your list look a little bit better. And we've all done that. You know, I'll do the interpreter at the end because that's going to take me 10 minutes on the phone to language line to be able to get an interpreter. That's conscious bias. We are choosing to see people later because of a different need. Resource allocation, digital poverty. We talk about digital poverty a lot. Now, my patients in Rusholme and Moss Side have all the kit and unconscious bias. Communication, language and understanding. Do we make assumptions about people that probably aren't true? The treatment offer that we give them, is it easier to say, oh, I'm just going to give them amlodipine because I don't need to monitor it and they don't speak English. It's going to take me ages to tell them to come back for U&E. You are making a decision on bias. Is that the right thing to do? If it is clinically the right thing to do, absolutely. If it's not, we need to look at ourselves and say, how do we make the right conditions to reduce our bias? And of course, unconscious bias. And there's loads online you can look at, but what I'd like you all to do is go back and challenge your own unconscious bias, because the only way to start to change some of that is to start to be aware of it. And this isn't a criticism, we all do it, but how do we make sure that we then address that? So a few slides about what we can do. So this is from the COVID vaccination programme. When you roll out something, when you do something, when you ask for a change in people, and they don't listen to what you say, you need to understand why. So why in some of our communities who possibly have less trust in complex systems, healthcare, policing, local authority than others, how do we help them understand that the change we're making is for them? We need to look at access. How do people access change? What information do they need? Not what information do we want to share? What is that information they need to make that right decision? And what is their motivation? There's some great books on motivational interviewing. I would suggest you have a look at them because they do talk about how we then push that back onto our patients in partnership to say, well, what is it you need in your life that would make that change? Barriers. We all talk about, oh, we've created barriers to healthcare. But what does a barrier mean to you? And sometimes people say, oh, a barrier is they don't have an interpreter or they can't physically afford the bus to get to their hospital appointment or the parking at some of our hospitals. But actually a barrier is anything that makes your journey different or slower to somebody else. And actually then if you look about barriers, we've got numerous barriers from that initial point of contacting your clinician to that end point of receiving aftercare. And there's lots we could do to perhaps reduce some of those barriers. And I'm sure you're going to hear some about the great work in different areas that has already started to do that, from design principles to post-process to how we work as a single system around a person to remove some of those barriers. A couple of national slides. Again, things I want you to think about. Where can you intervene to reduce health inequalities and help with deprivation? We can look at different levels of risk, people with the riskiest behaviour in terms of population health. We can look at those who have the most impact over time, where we know that if we intervene now, their lives will be different in the future. You'll have all remembered that poor child that died because of damp and mould in Rochdale. That is not okay. That is not okay in a modern society. So that intervention for that child was now with a high level of risk. So how do we put our limited resources where we want to go first? And of course, life course, dealing with childhood trauma for people who've had really difficult childhoods, and you'll hear from children and families next. Their outcomes, 50 or 60 years, we're intervening for their whole life course. And all of these are available on Public Health England's resources. You've got different levels with which you can intervene, and part of the role of an integrated care system is to pull together service-based interventions with community-based interventions and civic-level interventions. Price point of alcohol, where alcohol can be sent, vaping. You know, there's all sorts of things we can do at a civic level that we can influence that make a difference to the health choices people make. How many of you work or live on a high street which has multiple takeaways? we could intervene with that. We could say, actually, we don't want this here. We can do things differently. And there are some great VCSE groups working along healthy food offers on our hardest hit communities, and we need to amplify their voices. Last couple of slides. So this is up here as my greatest passion. Laura's spoken about hers, and mine is personalised care. How do we do things at scale, but also about people? This is about people. How do we translate what we know as best practice evidence to the person sitting in front of us? And when I'm training, I always, when my registrar comes in and says, this is the symptoms this person has, I said, who is the person in front of you? Because unless you know who that person is, your treatment will always fall short because you haven't personalised it to their condition. And the buy-in that you will get, particularly for areas of multiple deprivation, for asking the question, tell me a bit about you and how this affects your life, will give you a whole different set of outcomes. And that's important. And finally, the bit that's in my world and some of the others in the room is systems. How do we look at complex systems and really help with this agenda? Often we look at the top of the pyramid and we look at events and we change events. We do audit that change events, we change processes. We might look a little bit lower at patterns of behaviour. But do we look at the underlying structure of our health and care system and say we need to look at structural confounding issues that keep people in deprivation and reduce their health outcomes? And can we change our thinking with the bottom one?